Hello, friends. Thank you so much for joining the third DiSPLeN webinar that is on updates on management of advanced pediatric Hodgkin's lymphoma. So that is moderated by two very active and valuable members of DiSPLeN team, Jelena Lazic from Serbia and Cesar Nunez from US. So both are part of DiSPLeN, and Jelena is leading one of the key contributor in SIOP Europe Educational Committee, and Cesar is a very important part of SIOP Global Health Network. So I'm Mohammed Saghir Khan from Saudi Arabia. I'm a co-chair of SIOP Global Health Network. So we warmly welcome you on behalf of SIOP Global Health Network and SIOP DiSPLeN team. So just repetition who have attended the previous webinars. DiSPLeN is disease-specific portal for learning and networking. That is a new initiative by SIOP Global Health Network to provide additional learning avenues to SIOP members. This is a learning forum on various aspects of care directed to common curable cancers. And we are going to offer various learning sessions on case-based discussions, diagnosis and referral pathways, access to care, advanced diagnostics and therapeutic modalities. And invited faculty are the SIOP members with enormous experience and expertise, the disease experts, as we have three disease experts this evening. And then DiSPLeN will potentially enhance SIOP membership engagement and contribute to professional nurturing of SIOP Global Health Network members. So we are in the pilot phase, which is of 6 months duration, started in December. And basically, we are having objective to globalize the already existing smaller and regional groups on disease-specific learning. DiSPLeN team will coordinate education day sessions along with local SIOP Asia organizers during the SIOP Asia 2025 Congress, which is going to be held in Riyadh, Saudi Arabia from 12th to 15th of April. So you can see the QR code. So do a register and get part of DiSPLeN family on the education day during SIOP Asia Congress. So our ultimate goals are to expand the project to non-English language to engage global representation, connect with other projects within SIOP and SIOP continental branches, and actively interact with key global stakeholders and childhood cancer initiatives. So we already have two very successful, very interactive sessions on neuro-oncology starting in December on low-grade glioma, where we had Eric Buffet as a speaker, and the second session on medulloblastoma, where we had Mariam Foladi as a speaker in end of January. So these two sessions were recorded, and you can watch the videos on YouTube. There is a link I provided, and you can go to the DiSPLeN web page where you can find information about this great initiative. So today we have this session. We have three speakers, two presenting on European approach and one from North American approach. So this is on Hodgkin's lymphoma, and the next session is going to be held on Wilms tumor, which will be on 27th of February, 27th of March. So please mark your calendars for that session. So some housekeeping instructions. There are options to ask the questions. Rather, we want to it more interactive. We had plenty of questions in the last sessions also. So you can click on the question box at any point. There is no voice option for the audience, unfortunately, because of time constraints. And then the text answers you can post, and that can be answered by the expert in the text, or that can be answered in dedicated Q&A session after the presentations. After the session is done, you will receive a survey from SIOP office. So please participate in that survey and give your feedback. And after that, you will get the certificates of attendance of this very webinar. So just one last thing, we are going to have a SIOP meeting in Amsterdam in October, where the abstract submission is open and the deadline is 1st of April. Abstracts are welcome from everywhere. SIOP members can save up to 300 euros on Congress registration. Still, there is early bird registration ongoing. and we would have GHN scholarship for low and middle income countries. So get registered to SIOP Congress and get a chance to get the largest international pediatric oncology global community and professionals. So there is a link you can join on the website of the SIOP society. So let me hand it over to my friend, the DiSPLeN team, very active DiSPLeN team members and moderators of this very session. Dr. Jelena, over to you, and Cesar. Thank you so much.
Dear Sagir, thank you for the introduction. And I need to say first, good morning, good day, and good evening. It depends from where you're coming from my side as well. And we are very happy and honored to have such a good panelist today with us. First, we have Auke Beishuizen from Princess Maxima Center in Netherlands, who is the chief of Hodgkin Lymphoma Group and also very dedicated in our EuroNet, which is the European Network for Hodgkin Lymphoma Diagnostics and Treatment. Then we have Mary Tay coming from UK, London, from Royal Marsden Hospital, and she is the chair of Childhood Cancer and Leukemia Group, who is also devoted to lymphoma her whole professional life. Then we have, as Sagir already said, Cesar Augusto Nunez, who is coming from MD Anderson in Houston, Texas, from USA, and who is very valuable part of our education and family. And last but not least, our young pediatric hemato-oncologist, but also very experienced, who is coming from my center and who is going now to present one very challenging case. And please do not be shy, ask questions in any time. Goran, the floor is yours.
Hello, thank you, Jelena. It's an honor to be on this session, and now I'm going to share my screen and to start the presentation. So just a second. Okay, I hope everybody can see the slides. So today I'm going to talk about one patient from our hospital, that's University Children's Hospital in Belgrade, Serbia. So I'm sorry. So this is 16 years old patient. It's a male, and he came to our hospital because he had complaint like cough and fever that lasted for last month and malaise and fatigue that lasted for last week. He was examined at primary care hospital in Serbia, where they performed this chest X-ray, and as you can see on the chest X-ray, there is a large mediastinal mass primarily on the left side, and then he was referred to our tertiary care hospital. At the admission, he had elevated inflammation markers like CRP, fibrinogen level, and erythrocyte sedimentation rate, but his complaints were only mild. So soon after admission, we performed a CT of thorax, and we saw that there is a large mediastinal mass that was estimated, that was in the anterior mediastinum, more to the left side of the heart, and the tumor volume was approximately 150 milliliters. Also, on the same CT scan, we noticed on the right, you can see it on the right image, we noticed there is a large pericardial effusion that later turned out to be approximately around 700 milliliters. So the next day, we wanted to go to perform a biopsy of this tumor mass, but as you all know, the mediastinal masses are every anesthesiologist's nightmare because of all possible complications that can happen during procedure and during intubation or anesthesia. So first we had to perform pericardiocentesis, when we did that in the local anesthesia, and we removed around 700 milliliters of pericardial effusion. After that, the patient was intubated, but he remained on spontaneous ventilation when surgeons performed mini thoracotomy and took the small sample of tumor tissue. Histopathology revealed that this is a Hodgkin lymphoma, nodular sclerosis, and it was positive for CD30. And soon after that, the next day we started, the next day after we received the pathophysiology confirmation, we started treatment. This patient was staged according to Euronet PHL C1 protocol. So it was staged as second BE stage, and therapy line was the most intensive therapy in this protocol, that is the TG3. After first two initial OEPA cycles, we performed the interim PET-CT evaluation, early response assessment, and the DeVille score was 4. So we had partial metabolic response, and the CT showed a 55% reduction of tumor volume. So at this point, we thought these patients had some reduction of tumor mass, but he was going to need radiation after the chemotherapy was completed. And this is the interim CT image that shows the tumor volume is approximately 700 milliliters, which is those 45% of initial tumor mass. And the pericardial effusion was almost absent. Nevertheless, we gave him the first subduct cycle, and after that, the patient came back to our hospital with fever and no other complaints. We suspected that there is a progression of disease, and we performed the initial test, and we again had the inflammation markers elevated, like CRP 135, sedimentation rate 80, and fibrinogen extremely elevated. We performed a chest X-ray on that day, and we again can see the mass in the mediastinum, and we performed the CT the next day, and we showed that there is, the progression of tumor mass. At that point, we consulted our friend Professor Ratterbashi from Vienna, St. Anna Kinderspital, and we agreed that we should continue the treatment for this patient using brentuximab vedotin plus nivolumab, and we gave him 2 cycles of this therapy. After that, the patient showed a good response to therapy in terms of reduction of tumor mass and decrease of inflammatory markers. But however, PET-CT showed DeVille score of 4, so it is again partial metabolic response. We continued the treatment using brentuximab vedotin and bendamustine for further 3 cycles. And yet we managed to get the partial metabolic response, the DeVille score of 4, but the patient is, all this time, he is in excellent general condition. After that, we performed high intensity chemotherapy, beam, and autologous stem cell rescue. 1 month after autologous stem cell rescue, we performed the follow-up PET-CT, and we were very surprised to see that there is a progression of the disease. They will score 5, and the patient at that moment had no complaints. Also, as on the initial presentation of disease, we had elevation of CRP, ESR, and fibrinogen. So after that, we consulted Professor Ratterbashi again and decided to continue with EGIV and brentuximab vedotin for 4 cycles, and the patients received the last cycle of EGIV-BV this week, I think yesterday, and we have PET-CT scheduled in 2 weeks, and we performed HLA typing and found out that patient has no matched sibling donor, and we are preparing the patients for haplo or matched unrelated donor stem cell transplant. So I just wanted to sum up for these patients. So as you can see on this timeline, on your left side in the green, we have the initial therapy, first-line therapy, 2 times OEPA, 1 time subduct, and positive ERA PET-CT after the 2 OEPA. And then we have a progression. After that, we had 2 times BV plus NV chemotherapy and 3 times BVB therapy. After that, we performed stem cell rescue with high-dose chemotherapy. After which, again, we had a progression for these patients, and at the end, we had 4-time EGIV therapy plus brentuximab, and now we are waiting for continuation of this therapy in terms of haplo or matched unrelated donor transplant. Thank you very much. I'm going to stop the sharing now.
Thank you, Goran. We already have 1 question. Why a CT-guided biopsy was not done? So this is unfortunately the local circumstances. We have lost the dedicated pediatric thoracic surgeons. We have now some people who are on education, including the invasive radiologists, and hopefully in the next month we will start to do the ultrasound and CT guided biopsies. So this is something which was at the moment unfortunate situation for us.
Yeah, I can add to that question that soon after this patient was presented to us in November 2023, and in the November 2024 we had the first patient that we performed CT-guided true cut biopsy. So this is the future and hoping to happen in our center soon.
Okay, very interesting question for our dear friend Regine. Did the patient had any predisposing immunological disorder? Goran?
No, our patient did not have any immunological disorder.
Then is the question, how are you using tumor volume in your staging phase?
I'm sorry?
How are we using the tumor volume in our staging phase?
Well, according to the AeroNet PHL-C1 protocol, there is a exact reduction of tumor volume that need to be obtained to get the staging rate. But the tumor staging initially is not guided by tumor volume.
Okay, and very good question that maybe can the other panelists be included in. What is the outcome of autologous stem cell rescue if it's done only in partial remission? Does anybody else want to be included in this discussion?
Maybe I can add, because when it's not in complete remission, that means that I don't know the exact figures, but normally when it's in complete remission, you expect at least 80%, but when it's not complete remission, maybe you expect 40 to 50% survival at that time. So I think it's very, very important to get a complete metabolic remission, complete remission before giving the patient high-dose beam and stem cell rescue.
And
Yeah,
Mary, please.
I was going to say the same thing, yeah.
Okay. Then there is a question about cytogenetics of the patient.
Well, we had no cytogenetic abnormality for this patient. He had normal karyotype.
Okay, then also interesting question, which says, in a case of refractory Hodgkin lymphoma, refractory to monoclonal therapy, do we think to perform the rebiopsy if we have any doubt of diagnosis? Which we actually didn't have, but does anybody have from the panelists comment, is the rebiopsy necessary in these cases?
If there's a long interval between relapses, then one would rebiopsy. But if the relapse is occurring or there has been insufficient response, as in this case, one would not do a rebiopsy. Unless one is really concerned that it's not, that the original biopsy was insufficient or not diagnostic, I don't think we would do a rebiopsy.
And there is I'm sorry.
No, I agree with what Mary said, but it's also, you have to consider if it's easy done. If it's just a lymph node which you can easily remove, I would prefer to do that. But if it's, in this case, it's difficult because you have to do a CT guided biopsy, so that makes it more problem.
And I think that the next question will be answered by the presentation of Auke. So Auke, please.
Okay, thank you. I'm honored to be invited to give you a short lecture and to be part of the discussion. So I'll try to share my screen. I hope it'll work. I hope you can see it. If not, please say to me, then we'll move on. But okay, I was just asked to give you a sort of current overview about the two pediatric Hodgkin lymphoma we we did the last 2 decades. So I would like to tell you something about the current treatment options, the historical overview, and then tell you something about the results of the C1 protocol and next the C2 protocol and why we did the 2 protocols, what are the background of it. So first, I think the current treatment options are, of course, radiotherapy, and that's already very long known, chemotherapy since the 1960s, but also the allogeneic stem cell transplantation was also done since 1960s. And it is important because of the high dose chemotherapy by just killing the Hodgkin cells, but also the immunotherapy by the donor immunity, which can also fight against the Hodgkin cells which are there still left. And since the 1980s, immunotherapy is an option. We have the availability of monoclonal antibodies, for instance, rituximab, antibody drug conjugates, brentuximab, checkpoint inhibitors, and also CD30 CAR-Ts are more or less available, at least in some studies. So with the different treatment options nowadays, whether used in combination, the survival is high, currently more than 95%. Still, there are some cases which also just shown by Goran, who are very, very difficult to be cured. And we all know them. The therapy and prognosis, they depend on the amount and distribution of the Hodgkin lymphoma staging, as shown on the right side with the Cotswold modified Ann Arbor staging of the Hodgkin lymphoma, the B symptoms, and nowadays, when we look in the Euronet, also based on bulk and ESR, and also the tumor response is very important within the treatment of Hodgkin lymphoma. Nowadays, first line is chemotherapy, and radiotherapy most time involve node or involve field. The protocols we use, the Euronet 1, C1, and C2, are based on earlier GPOH protocols. And the first one published in 1982, the DAL HD 7-8, which used 2 treatment groups based on disease distribution. They used OPA courses and in the treatment group 2 OPA courses and 4 COP courses, but then combined with radiotherapy, 36 to 40 gray. And as you can see, the survival was high, 92% already in the early 80s. The next important protocol, and that time also seen as the golden standard, was the DAL HD A2 protocol, in which they use 3 treatment groups, also based on staging. And each group starts with 2 OPA courses, and then depending on the disease staging, 2 or 4 COP courses. And also the radiotherapy was dependent on the treatment group. And as you can see, the EFS was very, very high for the different treatment groups respectively. And you can understand that could, at that time, was the golden standard. The only problem was this high survival comes with a price. Early and late effects caused by the chemotherapy and radiotherapy are shown here. So you can see heart failure based on the anthracyclines and radiotherapy, or infertility caused by cyclophosphamide and procarbazine. Especially procarbazine was used very often in those DAL protocols, and the secondary malignancies, so anthracyclines and radiotherapy. And this caused us to think about how could we get rid of those bad late effects. And the 2 main problems were the radiotherapy, causing secondary malignancies or heart failure, and also procarbazine, who causes infertility. So what we did, based on those early protocols, we also had 3 treatment groups, and it is shown in the slide how those groups were divided. And every group started with 2 OEPA courses. That means vincristine, etoposide, prednisolone, and doxorubicin. And after those 2 OEPA courses, there was a PET scan evaluation. And based on that evaluation, patients would receive at the end of treatment, radiotherapy or no radiotherapy. The second important thing in this protocol was the randomization in consolidation between COP-DAC courses or COP courses. The COP courses were still have procarbazine, and the COP-DAC courses did not have procarbazine, but instead dacarbazine. And we want to show that the COP-DAC courses were as effective as COP courses, but would show less fertility problems as expected because the procarbazine was omitted. And you can see that the 3 treatment groups had more or less the same building as in the earlier protocols, with in TG1 2 OEPA courses, in TG2 2 OEPA courses, and followed by 2 COP or COP-DAC courses, and in TG3 2 OEPA courses followed by 4 COP-DAC or randomized COP courses. And they also received radiotherapy when the evaluation after the 2 OEPA courses showed no adequate response. The results of the C1 protocol has been published in 2022 and 2023 in Lancet Oncology with first author Christine Maus-Kurrels. And it is shown on the left side the PET-CT response after 2 OEPA courses. And you could see that at least in 50% of all patients, radiotherapy could be omitted. So that was a real breakthrough in those protocols used in a protocol used in nearly all of Europe. The other thing which was important was the randomization between procarbazine versus dacarbazine. And as you can see in the figure, the EFS appears comparable. And that means that within the C2 protocol, the COP-DAC is now the new standard treatment. And this is shown in the next slide. So again, you see the same building of the protocol, 3 treatment groups now called TL1 and TL2 and TL3, but they all received again the same OEPA courses, and there was an evaluation. But you see that there is next step randomization between COP-DAC and D-COP-DAC, and I will show you in the next slide what the difference are. And also you see the same that there is another slight difference is that there will be an extra course between after TL1. So when the patient was evaluated not to need radiotherapy in the TL1 course, then they received 1 extra COP-DAC course for consolidation. And in the next slide, you could see the difference between the 2 courses. So on the left side, you see the COP-DAC 28 scheme, and that's with prednisolone 40 milligrams per square meter, dacarbazine, vincristine, and cyclophosphamide. And the DCOP course 21 scheme is the difference. That's only 1 week of prednisolone. The cyclophosphamide was a little bit higher, so 500 milligrams per square meter compared to the 6 to 5 milligrams per square meter in the DCOP-DAC course. And etoposide and doxorubicin were added. And that was done in a randomization. And the other important thing was how can we omit more radiotherapy compared to the C1 protocol. So what we add was that's why the reason to give more chemotherapy in consolidation. So that's why we added the doxorubicin, etoposide, cyclophosphamide to the new protocol. And we said to each other, we have a next evaluation after the chemotherapy. And when that evaluation shows an adequate response, the radiotherapy could be omitted. Was there no adequate response, then the patient would receive the radiation with a higher dose on the rest of the tumor, which shows still dosal score 4 or 5. And in case of the DCOP-DAC courses, if the patient had at that time no rest tumor left, then the radiotherapy could be omitted. Next slide, I will show you some preliminary results of the C2 course. The TL1 shows an excellent result, so no EFS difference between the adequate response and the inadequate response patients. So the extra COBDA courses in those patients with adequate response showed the same EFS. In case of TL2 and TL3 and a good early response assessment, so adequate response, then it appeared that the DCOBDAC21 was better than the COBDAC28. And if you look at the inadequate response patients in both arms, then the DCOBDAC21 was more or less similar to the COBDAC courses and could be done in both options are available. And in the C2, the majority of patients, the radiotherapy could be omitted compared to the C1, where only 50% of the patients, the radiotherapy could be omitted. What does this mean for the future ERNET PHL protocols? Of course, we are busy thinking about it. What we now know is that radiotherapy can easily be omitted in a large part of the patients, but then you need more chemotherapy. Now, as we know, we have done a study with pembrolizumab, which combined with chemotherapy, and it shows promising results. And last year, Herrera et al. Showed that nivolumab in combination with EVD shows also very nice results, survival rates in Hodgkin patients first line. And what we also know is that current relapse protocols show high EFS rates with immunotherapy. So we think immunotherapy or chemotherapy in first line would be a very good option. Thank you very much. And I would like to stop sharing my screen and happily to take questions.
Dear Auke, thank you very much. And I think that our broad community now has a really more than good overview of what is happening, currently happening in Europe regarding Hodgkin lymphoma. There is an interesting question that is coming from low-income country who are not unfortunately able to perform PET-CT. And they ask, do we still take fever as for 3 consecutive days to be considered as B symptom? Because they do the bone marrow aspiration as we did in former times. What do you think?
Yeah, that's a difficult question because, of course, fever could be one of the B symptoms in case you have Hodgkin disease. Of course, the PET scan could omit the bone marrow puncture, and but before that, we all did the bone marrow puncture. So I think you should do it just for to be sure that you have not a stage 4 disease, and that's also very important. So I think that although you don't have a PET-CT scan, it's very important to do all the diagnostics needed to say something about the staging. And then, of course, the response is difficult. I can understand that. For in the ERNET protocols, the CT scan the PET-CT scan is very important. When that's not the case in your country, you should then look at the other possibilities you have, if you could say something about staging. So if you are able to do an MRI or a CT scan, that could give you a clue. Otherwise, you have to go on by based on the staging to give the patients the treatment available, and then discuss if radiotherapy is needed or not. So, but that's a difficult question. I can understand that.
Thank you. And another one, has been any concerns about etoposide?
Yeah, that's a very good question. Of course, we are worried about it, and especially you think what can happen is secondary malignancy more often in those patients. But what we did is we checked the amount of etoposide and checked it if it's based on the literature, if it is of the chance is higher, and it appears when we check that the chances are a little bit higher, but not that high compared to other studies and other amounts of etoposide given in AML, for instance. But of course, future will tell.
We need time, more time
Yeah.
for evaluation. Thank you very much. Mary, would you like to start now?
Okay, just give me a second. I need to make sure I get the right one. Okay, just making sure. Yes, so I'm going to be talking about Hodgkin's lymphoma and adapting our protocols according to resource. Can you hear me and see my slides?
Yes, please continue.
Yes.
Yes.
So this topic is quite difficult because I now live and work in the UK, and I'm part of the lymphoma group in the UK. But I'm originally from Pakistan and have continued to work closely with my colleagues in Pakistan. So I know quite a bit about the data coming from Pakistan. So I apologize for presenting data from that country, but I have read on data from other low and middle income countries and found it largely in line with what I am presenting, but will be happy to take questions later. So, oh, it's not moving. Yeah. So, as Auke has said, treatment of Hodgkin's is in some ways quite easy because this type of lymphoma responds to chemotherapy, it responds to radiotherapy, and over time we've had a number of chemotherapy protocols which have by and large shown good results: MOP, CLAVUP, ABVD, COPDAC, DCOPDAC, etc. And most countries or most centers would use a combination of chemotherapy and radiotherapy to reduce the long-term side effects of these agents. And we need to always try and find a balance between the treatment and the long-term side effects of treatment. This is because, particularly for Hodgkin's disease, the secondary deaths from second malignancies and other side effects can exceed the death from relapse if one is not careful and the right protocols are not chosen. So, I mean, this over time, as Auke has already said, the protocols have improved. We used to give large doses or covering huge mantle fields and inverted Y fields, and now the radiotherapy fields are much smaller. We focus on involved field radiotherapy, and the dose has gone down to from 35 to 36 gray to 20 gray. And these kind of side effects, which were often seen with undergrowth of tissue and cardiomyopathy, should be seen less. Then, as Auke said, alkylating agents like procarbazine can cause infertility and second malignancies, anthracyclines, cardiomyopathy and secondary malignancies, bleomycin, pulmonary fibrosis, etoposide secondary leukemia, and radiotherapy increases the risk of breast cancer. So all these things have to be considered when choosing different protocols. The dose of radiotherapy has gradually reduced in the Euronet protocols from being 36 gray to all involved areas to now 20 gray in areas that are not in complete remission. So that has been an advance. So when we go to resource poor countries, their constraints are different from those in the high income countries. And not only do they have to consider the long-term side effects of these protocols, but acute side effects as well, because you have a certain mortality, acute mortality, then children leaving against medical advice because of the toxicity or because of the cost of the drugs involved. And in order to learn this further, we did a brief study in 2016 comparing 50 children diagnosed between the Children's Hospital in Lahore, Pakistan, with the Royal Marsden, where I work. And when we looked at demographics, they used the Euronet PHLC1 protocol. They did not have PET-CT at the time, and they used CT scans to assess response after 2 courses of treatment. And they gave radiotherapy at the end of treatment to all patients. So in that sense, the treatment was different because it was very difficult to assess without a PET-CT which patients would not get, could avoid radiotherapy. So, but you can see from here that the demographics of the disease that they saw and what we saw was different. They had a huge number of patients, 22% of patients who were less than 5 years of age, whereas we only had 1 patient. The majority of their patients were between 5 and 10 years of age, whereas the majority of our patients were older than 10 years. The male proportion was it's more common in males, but for us the difference wasn't quite so stark, 60% versus 40%. Then the biggest difference was in the histopathology, mixed cellularity, and I know this has been presented from many other countries and groups as well. So there had 64% of patients who had mixed cellularity and only 10% with nodular sclerosing Hodgkin's disease, whereas for us, the vast majority had nodular sclerosing Hodgkin's disease. And then they also had more stage 3 and 4 disease, and about 90% of them had stage 3 and 4 disease. We had significant stage 3, 4 and disease, but not quite 90%. Then the other difference I found was somebody asked this question about bone marrow. They had bone marrow, and I know the numbers are small, but they had bone marrow involvement in 23 patients, which was 46%. And this was bone marrow not on PET-CT, but by doing a procedure, by doing an aspiration and trophine. And for us, the stage 4 patients had lung nodules in 18% of patients, where they had only 2 patients who had lung nodules. So, as I said, they used the Euronet C1 protocol, and of the patients who completed treatment, they had pretty good results, 84%, with 4% patients, 2 patients, which is 4% relapsing, and this, which is not, none of our patients left against medical advice, but they had 4% patients doing that, and then 8% patients dying with, 2 of those patients died of infection and 2 died of progression. So this deaths due to acute infection and leaving against medical advice were unfortunate. So then this is the other big cancer hospital in Lahore, Pakistan, and in their endeavor to find out which of their which protocol is best for their situation, they looked at different protocols that they had used in different eras. And this study was published in 2019, and they looked at their patients over the 10 years before that. And they had it was a retrospective study, 748 patients, and 412 got COP, DAC, and ABVD. Clevup and ABVD was used in 176 patients, OIPA and COP in 57, OIPA alone in 35 patients, and OIPA and COP-DAC in 33 patients. This particular protocol was getting more and more popular in Pakistan, and so this was more recent than the other protocols. And out of these patients, only 17% received radiotherapy. This was only for residual disease. And again, as in the previous study, they had 20% patients who were less than 5 years of age, and another huge chunk of patients, 45%, who were between 6 and 10 years of age. The male-female ratio was quite high, and stage 3 and 4 disease was again quite high. And they had bone marrow positivity in 13% of patients, so much higher than you would see in our populations. And they also found that patients who had bone marrow positivity had a lower survival than those who did not, 83% versus 95%. And they looked at the deaths that occurred using these different protocols, and they found that COP-DAC and ABVD had the lowest deaths due to infection, which was 2.6%. OIPA and COP had 21%. OIPA COP-DAC had 9%, and Clevup ABVD had 6.8%. So in their hands, the mortality and morbidity from a certain protocol was least with COP-DAC and ABVD. And when they looked at survival, they also found that for most of the protocols, the event-free and this is event-free and overall survival was pretty much the same. And for ABVD COP-DAC, event-free survival and overall survival of patients who completed treatment was 96%. So in summary, the overall survival of all the patients treated was about 86%, 5% died, 3% left against medical advice, and there was a small proportion relapsed. Then overall survival was 94%, event-free survival 91%, and their conclusion was that COP-DAC and ABVD was better tolerated with minimum side effects and also had good event-free survival. So then this protocol, the results from another hospital called Indus Hospital in Karachi, they also published their results of ABVD and COP-DAC, and they had 212 children less than 20 years of age who had presented between August 2000 and December 2012. The mean age was 9 years, and 20% were less than 5 years of age. Mixed cellularity was most common, 85%. And they used 4 to 8 courses of ABVD and COP-DAC, with 59% patients receiving 6, for 23% less than 4, and a small proportion, 12%, receiving 8. And residual radiotherapy was given to significant residual disease, and only 10% patients have had it, and their event-free survival was 82%, and overall survival 89%. So based on these data, the Pakistan Society of Pediatric Oncology produced a national protocol, I think about 2 or 3 years ago, for treatment of classical Hodgkin's lymphoma. And it is this: they do use PET-CT where available, but also CT and MRI where it isn't. For staging, treatment group 1, 2, and 3 are largely based on the staging on the Euronet protocol. Treatment group 1 are given 4 courses of chemotherapy, COP-DAC alternating with ABVD. And after 4 courses, they have an early response assessment. If there is complete response, then they get no further treatment. If there is inadequate response, then they get radiotherapy. Treatment group 2 are simply treated with 4 courses of chemotherapy, have an assessment, And then they have 2 further courses of chemotherapy. And if they have an adequate response, they have no radiotherapy. And if they have an inadequate response, they continue to have radiotherapy. And treatment group 3 similarly have 4 further courses, which means a total of 8 courses of chemotherapy. So the results of this national protocol are being collected, and it's part of the WHO Global Initiative for Childhood Cancer. And the results are not available for assessment, but this is the protocol that they have selected based on the data that they had from different centers. So it's just to conclude, Hodgkin's disease is curable in the vast majority of patients. Drug combinations with minimal acute and chronic side effects should be used. Radiotherapy, because of its extreme toxicity in children, should be reduced to a minimum. And just to add that in resource-poor countries, acute side effects also matter a lot because there is still a certain mortality from this treatment, which we largely consider as relatively low dose and outpatient base, but OIPA in particular has quite a few side effects with patients ending up with infections and in hospital, which is why they've gone to ABVD and COPDAC. And it'd be good to see what other countries have experienced. Any questions?
We asked many questions. So let's start. Something that maybe all panelists can answer to. Oh, that's already answered by other panelists. Okay, so first there were some thanks for comparing the results for low and middle income settings and from the audience. And then there is an interesting question that Auke you can answer. For patients with TOEIC score 4 or 5 response, on ERA PET, should one irradiate only the residual avid lesions or all the initially evolved sites, especially for stage 3 and 4? We often have trepidation in irradiating all initially evolved sites.
Do you want me to answer that? So when we follow the Euronet guidelines, and currently we have following the guidelines from the C2 trial that stopped a while ago. And so for treatment group 2s and 3s, we are using DCOPDAC, which means that when we do the late response assessment, if they are PET negative at that point, they don't get radiotherapy. But if they are PET positive, then they do get radiotherapy, and the PET positive areas get an extra boost. So I think they end up getting 10 gray boost to those areas which are still PET positive, and the involved field areas get 19.8 gray. So I was just uh, saying that we increase the doses of chemotherapy to stop us from children from getting radiotherapy, but the side effects of chemotherapy are also not negligible. And we have gone up on the dose of anthracyclines that these patients get, and they also get more etoposide. But just to remember that if a patient has stage 4 disease with multiple sites, the side effects of radiotherapy are still immense. And there is still a guidance that if the amount or the area of radiotherapy is going to be huge, you might consider giving 2 more courses of DCOPDAC to make the patient PET negative to avoid radiating so many areas of, well, depending on how many areas are involved, but if you can see if the mantle field and inverted Y field areas are involved, then it is a huge radiotherapy field. So again, it's always this balance between side effects and cure.
Auke and Cesar, any comments on radiotherapy?
No,
I think
I agree. Yeah, sorry.
Go ahead, Auke. Go ahead. Go for it.
Okay,
We
so
lost,
yeah,
we lost the possible.
one interesting question. Is intravascular thrombus common in Hodgkin, and what would be the best approach for treatment?
I think it's not that common. The only thing is what you see in Hodgkin's disease, that there is pressure on the different veins, and that causes sometimes that there will be a thrombosis. So if that's the case, I would suggest to give Flexiprine, so to give a drug just to cause that the blood clotting is less possible.
I agree with Auke. I think that for all this amount of masses in different places, particularly with bulk in the mediastinal mass, with compression of the vascular and respiratory elements, we don't see too much thrombosis. We should expect to see more, but we don't see it. And I think that at the end of the day, the treatment should be like a regular thrombosis.
Okay, I think that one question was definitely for Mary. What was the incidence of second malignancies in the protocol used in Lahore?
Oh, I don't have that data, I'm afraid. But just anecdotally, because I go there quite often, I haven't heard anything, but I don't have any long-term follow-up data, which will hopefully come out now that they are collecting as national as it can be, because you know there are 4 or 5 big centers which are taking part in this national protocol, and they are feeding data on REDCap, which is centrally being analyzed. So I'm hopeful that in the future we will have data, but at the moment I don't have any data. Or I couldn't find any published data either when I looked.
I'm not sure, is it for Mary or Auke? The question, how do you assign these 3 options of treatment for newly diagnosed Hodgkin?
You mean treatment group 1, treatment group 2, and treatment group 3?
I guess. I
It
Yes.
just
looks like that's the question.
I think yes. I mean, it's based on the staging and presence of B symptoms and E lesions, and so roughly stage 1A and 2A are treatment group 1, and then 2B and 3A are treatment group 2, and 4 is certainly treatment group 3, as are E lesions. But this is all I can say from memory. But certainly we look at the chart when we assign a group for treatment. Okay, do you want to add anything to that?
Yeah, there is one thing, because there is one difference between the C1 and C2, is that the TG1 in C1 had also patients with bulk and high ESR, and in C2 those patients went to the TL2 group. So TL1 has no patients, 1A and 2A, but has no patients with high ESR above 30 millimeters and high bulk above 200 milliliters.
Yep, I agree. Yeah, definitely.
Okay, the quick one, stage 2, cervical axillary with less than 1 centimeter abdominal nodes. Would you qualify for stage 2?
If you have a PET scan available, then it would be easier, because when PET is positive, then it's likely that those patients those lymph nodes are also Hodgkin. But if you don't know and it's a centimeter, then I'm not sure if it's stage 3.
Yeah.
And one interesting question, if PET is not available and we use CT, do we need radiography in low-income countries or not? That's a good one.
Do we need
Radiography, the
radiotherapy?
classical chest X-ray.
Oh, classical chest. Well, you'd either use a CT or chest X-ray to diagnose the sites of disease. So before we had CT, it was chest X-ray and abdominal ultrasound.
Yeah.
And then now we have CT and PET CT. Yeah. It depends on what's available, but obviously you would do an X-ray if, oh, is it necessary if you're doing a CT? Yes. I mean, if you're doing a CT, then it's not necessary.
Not necessary, definitely. Okay, is there a cap or absolute maximum dose for bleomycin?
I don't know.
I would have to look it up. I'm not.
Yeah, I've had to look it up. Yeah. Probably it will be, but I'm not sure.
Okay, and another question before we step the floor to Cesar. How differently is lymphocyte predominant mediastinal Hodgkin lymphoma treated?
Completely different. I'm sorry. It's all yours.
Oh, is this you're talking about nodular lymphocyte predominant Hodgkin's disease?
Yes.
Is that? Oh, yes, it's treated differently. And if you have a lymph node that has been completely excised, then we watch and wait. If you've got disease that is residual, low dose chemotherapy, CVP or RCVP are what we use. And I think the adults still use R-CHOP, but they too are going for watch and wait. If there's very low level disease that is completely excised. Is that what you would do, Cesar?
We do depends on the location. I think that the question was a mediastinal tumor, which is a little difficult to excise completely, different
Yeah.
to an axillary, inguinal, or cervical node that can be removed completely. When it's removed completely, at least in our side, we do watch and wait, and obviously there will be around 70 to 75% of event-free survival of 5 years with absolutely no recurrence. And for those that recur, there is the possibility to use combination of rituximab because this lymphocyte predominance, they have been demonstrated by single cell analysis that they are B lineage based on cryptic immunoglobulin rearrangement. They express CD20 and they have very good response to CD20 plus very low doses of chemotherapy, obviously depending on the stage. In general, the lymphocyte predominance has a presentation as a stage 1 and stage 2.
Yes.
Very unusual to see a stage 3 and stage 4. And when it's combined as a stage 3 and 4, immediately we have to start to think this is one of these lymphomas that may evolve, and usually they go to diffuse large B-cell lymphoma. So that is the kind of elements that we have to see. But in the situation of the large bulky mediastinal, when there is these difficulties, the other element that has to be considered is if this is a primary mediastinal large B-cell lymphoma, which is a little completely different entity. I think that is beyond the scope of what we are discussing. I just brought into consideration as a part of the differential diagnosis that can be exercised in one particular moment.
Yes, I mean, I agree with you fully. Most of the nodular lymphocyte predominant Hodgkin's disease that I have seen are peripheral lymph nodes, stage 1 and 2. And I've never seen a mediastinal nodular lymphocyte predominant. I'm sure it exists, but
Very
it
rare.
must be very rare. And then I have seen stage 3, and even though, again, rare, but the one patient I treated responded very well to very mild treatment, and there is a risk of transformation later on, which is why they need to be followed up, but they do respond very well. And the risk of relapse does not increase if you treat them less intensively, is my understanding. I mean, if you treat them intensively or treat them less intensively, they behave the same. So you might as well treat them less intensively.
I think that there are a couple of things that I would like to add to what Mary say in terms of the questions. So just for general principle, not necessarily every PET positivity means that there is a relapsed Hodgkin. And we have to keep in mind, because there are many elements that may produce PET positivity, not necessarily mean that the Hodgkin has relapsed. And that is what is coming to the point that somebody was asking, do we need to do biopsy in these things? And I think that Auke may answer that question. Yes, we need to do some assessment there. In anything that is PET positive, do a biopsy, because the PET show us where there is activity. It does not show what is the cause of that activity. So I think that that is something that we have to keep in mind. And when there is doubt, do the biopsy. And I think that this is the most important. At the end of the day, you may have the proof histopathologically, and that is a huge evidence that help you guide what you are dealing with in terms of this patient that they have some possible recurrent disease.
I fully agree. We would, if there's any interval between relapses, we would do a biopsy. That would be the default. Yeah, you wouldn't go just by PET positivity.
Sagir signaled me about the question that he knows that is, how to say, prominent in low-income countries, how to exclude the tuberculosis prior to the treatment.
Biopsy. And I see that I have. As a matter of fact, I see that Auke showed the picture of Thomas Hodgkin. And when you reviewed his article, his original article in the Transactions of the Royal Society, most of the patients, they were tuberculosis. That was the original, that was the way that Hodgkin came into place. So I think that what he did was to show in the biopsies that is one of the things that made difference. And I would like to listen from you guys. What do you think about it?
Yeah, I have not come across tuberculosis too often recently, but biopsy, and then where there is suspicion, Montu's test and T-spot test, another test for tuberculosis.
Yeah, I agree. We luckily don't see that many tuberculosis, but I've been in Malawi and there they see it. So yeah, you have to check if that's the case, because you have to treat it. And especially when you treat with chemotherapy in the patient who has TBC, yeah, probably the patient will be in really trouble. So you must know the diagnosis.
Yes, definitely.
We have also many interesting questions. We already answered nearly 40 in exception of these live ones, but we need to continue. So Cesar, the floor is yours, and hopefully we can manage to answer all the questions in one or another way afterwards.
Before, and I apologize, before, I think that Regine made a very good question. If the patient has a primary immunodeficiency and it relapsed, do you do auto or allo? Most likely allo will be better in terms of that rather than the auto. He will continue with immunodeficiency and will be a major problem there. But anyway, obviously it's open to interpretation and your comments. So let me check here this. That's okay, guys?
Yes, it
okay.
is.
Yes.
Thank you. So, two things. And I bring historical point, and I see that many of you have done that one. MOB, the first chemotherapy agents, that combination of chemotherapy agents was brought into consideration in 1961 with the article in 1970. And that was here, and in the other side, Gianni Bonadonna in Milano, I think that published the ABBD in 1973. So I think that this topic is going to be interesting, and I'm going to show you For some of you, that will be interesting later on. Because in this moment, we are close to 70 years away from this. So many evolutions in the children's oncology group. I think that this patient that you present is a very complicated patient, but how presented? So the diagnosis is a stage 2B bulky mediastinum. And that by itself is a major problem because the way that depending on the protocol can be arranged for the stage, can be arranged for the bulky, can be arranged for the B. So it could be a little different. So here is, I'm going to show you some of the elements that have been used in different of the children's oncology group protocols and how it's evolving this scenario. If this patient present to our group 15 years ago, he will be eligible for this protocol, HOT 0031, that is stage 2B, and this with or without bulky disease, and low stage with bulky disease. So this patient received 2 cycles of doxorubicin. I'm gonna try to see if you can see the laser. 2 cycles of doxorubicin, bleomycin, vincristine, etoposide, cyclophosphamide, and prednisone that we call ABB-EPC, followed by CT or PET evaluation. Initially was considered CT, PET evaluation came into place a little later. And the idea was if the patient has a good response based on a specific defined criteria, it will consider a rapid early responder. They will follow with 2 more cycles of ABB-EPC, and later, after 4 cycles, it will go to complete response evaluation. If the patient is in remission, there will be randomization between involved field, and that is one of the questions that somebody make, if this is involved field or not. And if the patient is in no CR, it will be not random assigned to involved field radiation. If the patient is a low responder, will be randomized to 2 cycles of ABBTC in sandwich with 2 cycles of DECA, which is dexamethasone, etoposide, cisplatin, and cytarabine. And all the slowly responder will be assigned to receive involved field radiation. So what happened if the patient is stage 2, that is in this case, if the patient is a rapid early responder, 87% event-free survival, if there is less than response, still this is very good, but if the patient is a slow early responder, 76% event-free survival. If this is bulky disease, the association is lower, 73. If this is rapid early responder, will be around 86% as well. One of the things critical for this protocol is that why the stage 2, they don't do very well. Guess what? One of the things that happened is that these patients that they were 2B bulky mediastinum, they're one that start to enrich those subset that they don't respond very well. So in almost 1,712 patients, the 4 years event-free survival was 85%. Rapid early responder, they were 87% versus a slow early responder. So here was an important difference. If the patient in rapid early responder in complete remission continued to be 87%. And this was for those patients that do not receive involved field radiation versus involved field radiation. So that means that if the patient is a rapid early responder and is in complete remission, the addition of involved field radiation literally add a slightly increase in the survival, but was not significant, statistically significant. Therefore, in one particular moment, those patients, they can omit the radiation with all the toxicity and still they will have very, very good survival. In contrast, in the slow early radiation, and here was part of the reason that I bring this particular protocol, because they didn't do very well, doesn't matter what. A slow early radiation with DACA or without DACA, they didn't do very well. They require radiation. And the critical elements of this protocol, they were early response and really support a therapeutic decision in the future. In that way, patients that they are rapidly responded, that they are in complete remission, they will do very well without radiation. But those patients that they are a slow early responder, they need to have augmentation of the treatment independent of what has been done in the protocol, particularly if they have PET positive disease. And here you have some of the elements involved with radiation or not. And here the patient with DECA or no DECA, they didn't do very well if they are a slow early radiation. So if the patient arrived a little closer to our time, perhaps around 10 years ago, what will be what we do? We will do HOT 1331, that was the addition of brentuximab with chemotherapy to pediatric Hodgkin. And in that particular thing was an open label, patient 2 to 21. And I put it specifically here because patients with 2B with bulk tumor, they were classified as patients that could go into this particular group of high risk. And that is one of the points that I'm trying to make to you guys. The 2B bulky tumor, particularly bulky mediastinal disease, they are not good tumors. This is not a good disease. The same happened with this stage 4. We know that the high risk and the highest stage, they're associated with less event-free survival. They received 5 cycles of 21 days with brentuximab vedotin associated with modification of the ABPC that was done before. It was removed the bleomycin in this protocol. And there were 2 groups that they were randomized. The group with brentuximab with chemotherapy and the standard care group that was the conventional with the addition of bleomycin. PET after 2 cycles and the slow responder, they were classified, and that was one of the questions. In the chat, they were classified as a Duville 4 or 5, and rapidly responded, they were classified as a Duville 1 to 3. Now, here is one of the critical elements that was one of the questions that was done there. It was in both field radiation for this particular protocol, it was changed, and I think that Mary alluded to that, to in both site radiation. That means those that was giving radiation toward the site that was positive after the first cycle of therapy. Or those that they have large mediastinal adenopathy. So here are some elements of what we can do. There were 600 patients, of which 587 eligible in 153 institutions with a randomization of 1-to-1. And with a follow-on of 40-to-1 patient, the event-free survival was very good, 90-to-1% in the group that was brentuximab and chemotherapy. And this is one of the key components here, because for this high-risk disease, the addition of brentuximab and the non-chemotherapy that we were using, that demonstrate clearly that was benefit. 82.5 patients in the standard group. So there was a major difference between these 2 groups, suggesting that the addition of immunotherapy to the conventional chemotherapy from the beginning, to begin with, that was good and provide good benefit. Having said that, the both side radiation, there was no major difference between the brentuximab and the other group. But here was another thing. There was not the need from the both field, but in both side radiation. The toxic effects were similar in both of the groups. And here you will have the curves that demonstrate that the patients that they were slow responders treated with the standard of care. That means that the ABBEPC, they didn't do very well compared with the addition of the others, doesn't matter what, with the addition of brentuximab. So that means that immunotherapy was working better. The 3 years event-free survival, I think that was very similar, but the critical issue here is the stage 2 bulky. There were a randomization that, as I mentioned to you, similar to both of them. There were 62 patients in the brentuximab chemotherapy group versus 59 patients in the standard group. And look, this one, the bad events, there were only 1 in 62 in the brentuximab chemotherapy versus 10 among 59 of the standard care. So that, for me, is telling a lot of information here by using as a front line treatment. But what happened is this patient arrived a little later. what happened in the patient right now. That is consideration, and this is part of the tricky situation where we classify the 2B bulky mediastinum. So why is coming into that? Because there was this protocol, the S1826, that was a phase 3 multi-center open-label randomized trial in 256 institutions of the Southwest Oncology Group and the National Clinical Trial Network that include many of the COG institutions. And the idea was to compare nivolumab with ABD plus brentuximab and ABD, and that was for advanced Hodgkin lymphoma, and that was a combination between adults and pediatric based on many protocols from Europe, from the States, and from different places that they was demonstrating that the addition of checkpoint inhibitors in relapse, they were very good. They were producing very good event-free survival, and the combination with chemotherapy was also suitable to produce. But here is the critical issue. After almost 60 years, we go back to the ABVD backbone of the protocols. So in that way, we go back to Milan, to the area of Gianni Bonadonna, and to use the same backbone that he was using. So this is very interesting. Why? Because there were 3 groups based on the age. And here is one of the things that is important for us, because there was a specific grade for pediatric patients between 12 to 17, in which 118 they were randomized to nivolumab, 118 they were randomized to brentuximab. We know from before that brentuximab plus the chemotherapy was very good. And later, other randomization for patients between 18 to 60 and patients that they are over 61 years old. Stage 3 or 4, newly diagnosed Hodgkin lymphoma. And this is important, newly diagnosed. So the randomization was between these 2 groups, as I mentioned to you, and radiation therapy was directed to residual metabolic activation after the end of the treatment. So what happened here, in contrast of the previous protocols, they were doing PET scans at the beginning of the treatment, PET scan at what is called PET2 after 2 rounds of chemotherapy, and so on, PET4, PET6, or whatever that you need to do until the end of the treatment. Here, the PET2 was done, but was not required to be a decision-making point. It was done, but was not an element that to say, this is going to change treatment. The patient continued and was done at the end of the treatment. That was for the purpose of the evaluation of the protocol. The primary endpoint was progression-free survival as defined as you can realize there. There were 994 patients randomized, 970 including the intention to treat for efficacy analysis. In the second, there was a first interim analysis here. And this is very important. The first interim analysis was done at 1 year of the protocol, of 12.1 months of the protocol, and was already showing that the patient that received nivolumab and ABD, they were doing better than the patient that they were doing brentuximab and ABD. However, there was a very short period of observation, but the trend was already there. So the decision was, okay, we need to get a little more information, more data, more time. And when was done at 2 years, at 24 something months, the 2 years demonstrate progression-free survival of 92%, newly diagnosed, 92% for nivolumab plus ABD versus 83% for brentuximab plus ABD, which produce a good evidence that support that the addition of the checkpoint inhibitor plus chemotherapy produce very good results. One of the things that is very, very interesting, and definitely we need to think about it, and we need to think about it seriously, how many patients receive radiation at the end of the treatment? Only 7 patients receive radiation. So that is a dramatical, and I think, at least for me, this is one of the key elements that we can say for this protocol, that reduce the possibility of one of the major elements of toxicity that we encountered in Hodgkin lymphoma, which is the radiation therapy. In most immune-related adverse events were infrequent with nivolumab. Brentuximab vedotin was associated with more treatment discontinuation, particularly with a little bit of more toxicity based on fever neutropenia. Patients required more use of GCSF, and there were other toxicities associated with this. But overall, it was well tolerated. Nevertheless, 83% was not too bad for this, but obviously 92% is better. So in that way, if we compare to the case that we presented, if the patient has between 12 to 17 years, and I hope so that you can see the laser, but if not, please follow the line where the first upper red arrow is located, and you can see that the number of events, there were 7 among 118 in nivolumab versus 21 with brentuximab arm. That was in favor of nivolumab. And in the patient that they were these symptoms, something similar, 29 events in this number of patients, 288 for nivolumab versus 54 among 273 in brentuximab, supporting that nivolumab and ABD, and ABD was better. So with that, I conclude my presentation. And what I am trying to say, what I am trying to show is how we can approach this patient from the beginning. It's a little contrast, it's a little different, but at the end of the day, I think that the different approach that we have between the North American and the Europeans are very good. Both of them, they are providing fair amount of improvement through the time. And I think that the question is, now that we have a little more elements and a little more time, we can dissect a little better what are the real patients that they are going to need a little intensification, and perhaps that is going to help later the way that we can approach these patients. And with that, I am going to conclude. I am going to stop sharing here, and I think that we can open the floor for more questions. Thank you, guys.
Dear Cesar, thank you very much. But since we need to wrap up and finish in 2 minutes, I have keeping the one main question from the start. That was one of the first questions, and we will direct all other ones. Please, for the participants, do not be worried. You will get a written answer for your questions. So there were more questions about tuberculosis, but there was a lot of questions regarding relapsed Hodgkin and the Hodgkin with underlying conditions such as primary immunodeficiencies. So I think we need another webinar for that, for approach to the children with underlying conditions and relapsed Hodgkin. But now I would like to get back to the question that we had just right after the Goran's presentation. How we can send this child into further remission? Is there any way? So with the answers to this question, I think we can close this webinar greatly. Please, who wants to start?
Well, I'm happy to start. It is a very difficult question, and it's fortunately not many patients get to that point. But I had a patient who kept relapsing and then relapsed post allogeneic transplant as well. And the lesson I learned is don't give up. And in that case, I gave sort of like an adapted OIPA again, and then nivolumab again. And then there was one particular site that wouldn't go away, so we gave radiotherapy to that site because we couldn't biopsy it. And the child has now been in remission for 2 years. So what I learned is that there's no standard way of treating these patients, but if you keep, depending on what you've given before, if you give sort of treatment that they haven't had or that won't add too much to the toxicity, then you can keep them going and get them into a more permanent remission. But in that particular case, we reused the nivolumab. That at that time, nivolumab was the drug that we were using, and so having given it before, she relapsed, and then we did this transplant, and she relapsed, and then we gave some more modified chemotherapy and nivolumab plus radiotherapy, and she is still alive. But I don't think there is a standard answer as to what you would do, but I leave it to Auke and Cesar to give their opinion.
If I can add, I agree completely. It's a very difficult case. The only thing he did not have received yet is radiotherapy.
Yeah.
So I would try to get him more in remission, maybe with other courses such as DAP, so it's dexamethasone, high-dose RSC, and cisplatin. That's also a possibility. You can combine it with brentuximab. That is done by the adults, a Dutch group who published that in Hematologica. And then what you should do before the allotransplant is just radiate the disease places where something is left with radiotherapy. I guess that's the only other way. And I agree with Mary. You still could do other options, especially why don't you use nivolumab with AVD? It worked very well in as first line treatment. So you could try to do it because I think it's very important to get the patient in remission before the transplant.
Yes, I would agree. If you can get him down to a few sites, give radiotherapy because we try and avoid radiotherapy because of its all toxicity, but it is a life-saving mode of treatment
Modality, yeah.
and should always be given. I think Caesar.
Yeah, radiation therapy may help to cure this guy. And at the end of the day, I think that the question is, what is the worst toxicity? And I have learned is something that not necessarily can be shared, can be acceptable for everybody. The worst toxicity, at least for me, is a recurrent refractory tumor that is nothing to do. Because the end is only one, is death. That is the worst toxicity. So in that scenario, with that premise, in a patient that has been so refractory to multiple agents, the addition of radiation therapies, I think that it may produce a lot of good things for him to try to put him into remission before the transplant. If had been used nivolumab, I agree with Auke that you can try to use pembrolizumab. That's another thing because I think that in the way that they work, sometimes we can use one, we can use the other, and we have seen this combination. And there are other things that can be combined that have been done there, but I think that there is not a standard of care after the second relapse of anything. It's not. It's whenever that the patient needs, I think that you have to look what is the specific of the patient, if there is any genetic marker in the information that you have received from the biopsy, that you can try to figure out if the patient acceptable for any phase 1 or phase 2. That's another possibility. I think that there are some elements that can be used there. I don't want to mention it. Because I think that if the patient has not received radiation could be considered there. We try to avoid radiation from the beginning, but in this particular case, I think that there is probably the best option that the patient could receive in association with this. Now you have to be mindful of the interaction with some of the checkpoint inhibitors. And I think that this is something that you may consider because the patient, if they receive the checkpoint and receive radiation, they could have this immune reaction that it could be something serious. So as long as you can keep the risk and the side effects on check, I think that could be a good element that helps you to control disease and take the patient to the next level for the transplant.
Yes, just to add, I mean, my patient had received radiotherapy at another site before, but we still gave more radiotherapy to this other site, so radiotherapy in these difficult cases can be life-saving.
Yes. Guys, I think that we are getting to the close, Jelena and Mohammed, of the seminar. Before that, I would like to say thank you to Goran, thank you to Auke, thank you to Mary, to Jelena, to Mohammed, and also thank you to Susan, Anelia, Tessie, and Regent from the SIOP to allow us to have this opportunity to share all this information with you guys. And I think that is the DiSPLeN element inside of is providing a good forum to share difficult cases, to share information, clinical and research information that can be useful for the future for you guys. And with that, and I don't know if Sagir wants to say goodbye to everybody, but at least from the point of view of the seminar, excellent presentations, excellent discussions. We have learned a lot for you guys, and I appreciate on behalf of Jelena and myself that you were able to come together and do a wonderful presentation and discussion of this case. And there's a lot of things that we can do for the future in this learning process. Sagir.
I just want to say prior to saying
Jelena.
that I'm happy that we had discussion, 3 continents involved.
Exactly. Yeah, that was fantastic session. Definitely, we learned a lot, and it's a good interaction. I can see 46 questions or comments in the question answer box, so we can answer those questions shortly. Thank you so much for Dr. Mary, Dr. Cesar, Dr. Auke, Goran, and Helena for having such a wonderful session. So we would having the 4th webinar, DiSPLeN webinar on 27th of March, that is on Thursday. It will be on 1:30 p.m. Central European Time. So we will share further information. So just don't forget to fill up the survey form and get the certificate of attendance. Thank you so much.
All very much.
Sagir, you are the good one in this. Are you going to take the picture with everybody?
Yes, of course. I have taken a few already.
Okay.
Thank you so much and goodbye.
Thank you for inviting me. Thank you so much.
Thank you.
Thank you, guys.
Thank you.
Nice to see
Enjoy.
you.
Thanks.
Bye-bye.
Bye.
Bye-bye.